Welcome, and thank you for joining us in the session, Patient Harm and UHC. Is data being captured well? How are we protecting patients? Moderated by Dr. Neda Milewska-Kostova, Vice Chair at the International Alliance of Patients Organizations.
Hi, good morning, good afternoon, good evening to everyone. Welcome to the session on the patient safety and quality, actually. Firstly, before we start, let me wish you a happy Patient Solidarity Day, which is today, and it is celebrated for nearly a decade, initiated by the Maurice Moses Foundation in 2011 in Africa, whereby this foundation started to use this movement as an opportunity for patient advocacy in order to highlight the importance of patient safety and how it should be integrated into the patient-centered healthcare systems. With this one, I think this session really sits well with the celebration of the Patient Solidarity Day. And the patient safety and quality are really integral part and should be integral part of every healthcare system. While patient safety is a concept, patient harm is actually the consequence of not embedding that concept nicely and properly within the healthcare system. And this harm is something that we all, as health professionals, as patients, and as societies, should be able and should be willing and striving to avoid at any cost. Today, in this sense of how we really try to capture the patient harm within the UHC as a consequence of the lack of patient safety and quality. We are having 3 exceptional speakers who will be telling us different perspectives of how we capture the data, how we try to use that data in order to prevent further harm, and how this should be a lesson or experience that should be taken forward to every healthcare system globally. Today with us, we have Dr. Vivekanand Jha, who is the Executive Director of the George Institute for Global Health in India. Welcome, Dr. Vivekanand. He's also the Chair of the Global Kidney Health at the Faculty of Medicine, Imperial College London, and the President of the International Society of Nephrology. Welcome once again. Then we have with us Professor Kok Kian Tan. He is the Group Director and the Senior Associate Dean of the Sync Health at the Duke US Institute for Patient Safety and Quality. He is also the Chair of the National Quality Council that serves as an advisory body to the Ministry of Health in Singapore. And he is also initiator and a visionary of the Sync Health Patient Advocacy Network, SPAN, that really tries to learn and get the experiences of patients through the system and see how they would fit into learning for the others not to repeat those mistakes. He's at the same time also WHO consultant on patient safety for many, many years. And last but not least, Dr. Bhupendra Rana, who is the Chief Executive Officer at the Quality and Accreditation Institute in India, and also former director at the NAB Quality Council of India. At the same time, he will share, and he has a great experience within the International Society for Quality in Healthcare, ISQA, where he served as a board member, and he's presently serving as a chair of the Accreditation Council of ISQA. He's also, I'm very pleased to say that he's also part of our scientific advisory board at IAPO, and we are getting the chance to really use his expertise whenever we feel at IAPO that we need such expertise and such people. Thank you so much, Dr. Bhupendra. Welcome as well to this panel. So just to set up the scene a little bit, as I said, patient safety and quality should be an integral part. And if it was an easy issue to handle, probably we wouldn't have been here in this session. However, it is a very complex, since the healthcare systems are complex and patient safety and quality is actually a cross-cutting, it has to be present in every aspect of the healthcare system. But how and whether and why we are not managing to do this, and what are the lessons we are learning, and how we can improve this battle in including the patient safety and quality, we will hear from our speakers, as I mentioned. I would like to first invite Professor Vivekanand Jha to share with us his perspectives on how we are actually trying to protect the patients from the, let's say, from the start of the cycle, meaning from how we do the research on the health systems, on health systems, health services research, and so on, and how we can actually use those that research data or that information to improve the patient safety as a concept and as element of the health systems. Professor Vivekanand, the floor is yours.
Thank you, Dr. Milewska. And first of all, I would like to thank the IAPO, to Kavaldeep, and to Dr. Milewska and other colleagues for inviting me to come and join this illustrious panel with Dr. Tan and Dr. Rana, Dr. Semi, and many other colleagues. So thank you for that. I think you very nicely set the scene by describing the background of the issue that we are here to discuss. And since I'm going first, let me just highlight and pick a few points. The co-positioning of the two words, safety and quality, is extremely important. So patient safety is directly linked with quality, is something that we should not forget. Dr. Milewska, you also use terms repeatedly, patient-centeredness and healthcare systems. So I think those are other two things that we must keep in mind while we discuss any issue, specifically the issue of patient safety and quality. Because these issues are all linked to how our healthcare systems work, how people access healthcare. Are our people able to access guideline-based therapies for the various conditions? And is the system of quality control respected by healthcare systems? Does it appropriately receive a reward? Is there a cost to it if there are lapses in safety, etc.? We also need to, when we broaden the use of the term healthcare system, keep in mind that our healthcare system is actually quite big. It doesn't just include the hospitals that we normally go to and practice, but it also includes, for example, informal healthcare providers, especially in rural areas, when you think of low resource settings. It also includes both private sector and public sector, both of which have different incentives and disincentives in terms of patient safety and quality. Now, if we ask the question, are patients able to access guideline-based therapies? The very clear answer to that is no, not to the extent we would like to. I can tell you from our research, which is mostly around non-communicable diseases like diabetes, hypertension, kidney disease, cardiovascular disease, that the gaps extend throughout the spectrum of healthcare delivery, from awareness of the condition. And this lack of awareness is not only at the level of the people or the patients, but also at the level of healthcare providers, unfortunately and surprisingly. Knowledge of diagnosis. Even if the people know that they have a health condition, for example, hypertension and diabetes, the number of people who actually receive treatment for those conditions, even after receiving treatment, are they reaching the appropriate treatment targets that should be the norm for those conditions, and are there appropriate monitoring systems in place? So there are gaps at every single level. Patient safety is also importantly linked to access to essential medicines and diagnostics. And there are plenty of examples where people don't have, even after, despite knowing the fact that they have a disease and what is the treatment for that disease, they don't.
Professor Vivekant, you muted by mistake.
Sorry, sorry, yeah. Hopefully you didn't lose too much of what I was saying. So I was just talking about access to essential medicines and diagnostics. And we shouldn't forget that healthcare safety is also directly linked to lack of these. If people don't get appropriate medicines, they will resort to something else. And lack of access to diagnostics is an evident problem around the world. In many parts of the world, healthcare depends on use of generic medicines, and I'm sure Dr. Anna will talk more about those things later on. But quality control of generic products, especially with biosimilars coming on board, is an important issue in these settings. Use of generics is very helpful because it cuts down the cost and makes treatment more accessible to people, but we shouldn't forget about the issue of quality. Then the big one, what are the mistakes that are made in hospital? And here it might be useful to just recount some of the data. So there is a Johns Hopkins study which says that more than 250,000 deaths take place in US every year as a result of medical mistakes. And if medical mistake was classified as a cause of death, it would be the third largest cause of death in the United States. Around the world, the WHO estimates that 2.6 million people die as a result of medical mistakes, and another 136 million people are harmed. Fortunately, most of these harms are minor and they don't result in long-term consequences, but harms do take place. In United Kingdom, almost 100 million pounds are spent every year because of medical mistakes. So these are important consequences that our societies face in terms of the number of lives lost and the cost of healthcare delivery in these situations. So then, having recounted all of this, are there things that we can do? We can, of course, do many things, and we have at our access now. Technology has made available a number of elements that can be used to improve the kind of care. And I think technology has to be in the center of everything that we do, our response to reducing patient risks and improving patient safety and quality. So the widespread availability of mobile devices is talked about everywhere. And that is something we should leverage very strongly, not only for care delivery, but also to measure safety, measure quality, and ensuring improved safety and improved quality by use of appropriate algorithms. There are now, buzzwords like artificial intelligence, machine learning, etc. They are used, but they have a lot of potential in helping us get better at doing what we need to do. Because in the past, we always had to think about how do we improve quality. You had to, look for appropriately trained workforce who can monitor quality and so on. But fortunately, with the use of technology, that requirement will become less and less. And the technology itself will probably be able to do much of this. We also need to perhaps enhance communications and increase healthcare workforce mobility. This can be done through more and more real-time access to healthcare records and leveraging the existing healthcare record system and putting in place these healthcare records where they don't exist is something which is important. And quality monitoring and safety monitoring should be built into all the EHR systems as they are being developed rather than come in as an afterthought. Data linkage is critical, and many countries do that already. For example, the United Kingdom and some other countries, they have now increased ability to link data from different data sources. Some countries have remained quite backward in that, which includes, unfortunately, United States. But I think for all of us who are developing these technological solutions at this stage, doing this right in the early stages of our preparation is an opportunity for us, which the others will have to build in as a later point of improvement. And the final point I would say is that we should use this technology to also increase personalization of care. So as the care becomes more personalized, the likelihood of mistakes will go down. For example, we will perhaps also not use a blunderbuss therapy for everyone. And the specter of antibiotic resistance is right in front of us. Had we been able to use appropriate antibiotics in a personalized manner for people who needed the right kind of antibiotic, we perhaps would not have been at this situation that we find ourselves in. And for all of this, we also need the patients to bring on board. Patient perspective is important. So patient centeredness was the point that you made. So I will finish with that. So using patient perspectives and using all of that to drive our advocacy is going to be critical in this exercise. So once again, thank you for inviting me. And I look forward to hearing from other colleagues and to the discussion later on.
Thank you, Professor Vivekanand. This was a very important setting of the scene, as you said yourself, building up on how we can use, where the mistakes happen, where should we search for them, and where should we try to improve. Now, moving from where we can identify them to where we can actually, by locating them, start to correct or teach the systems to learn about them and not repeat them. We will hear about this from Professor Kok Hianantan, who will be sharing with us how Duke and US, how the university hospitals at the Singapore Duke and US are trying to work together alongside with patients to teach the systems how to not make mistakes. Floor is yours, Professor Tan.
Sorry. Thank you, Dr. Nida. I will share my screen.
While you are sharing your screen, I just wanted to mention that participants can pose their questions in the Q&A tab, and we will be taking them for the discussion at the end of the session. Thank you very much.
So, thank you. First, I'd like to thank the IAPO for inviting me for this particular Congress. I think this is a very important Congress, as I think patient safety is important to improve the care of the whole world, especially at the Asia Pacific region. I'd like to stress upon patient safety and quality as a framework for the UHC to protect patients from harm. So this is the definition of universal health coverage, basically that all individuals and communities receive the health services they need without suffering financial hardship. And I think it's important to put that into the context of patient safety and quality, because this is a key for a good UHC. There has been a high global burden of unsafe care. As you heard from the first speaker, there is really a lot of unsafe care and poor quality care that actually affects the delivery of the care. I'd just like to emphasize, to add upon that, that in the low and middle income countries, up to 1 in 4 patients are actually harmed. And up to the 60% of the death that is amenable to healthcare, this is relating to poor quality and unsafe care. And also to mention that it is not just happening in the hospital, because the burden of unsafe care actually comes from the primary and ambulatory care setting itself. So unsafe care causes a lot of harm and is costly as well. So as mentioned, UHC will not be worth achieving if healthcare itself poses a threat to the people's health. So the key to UHC is having a good patient safety and quality framework nationally and globally. So what is patient safety? Patient safety is actually a framework of organized activities that creates culture, system, processes, procedures, behavior, technologies, and environments in healthcare that will consistently and sustainably lower risk, reduce the occurrence of avoidable harms, and make error less likely, and reduce its impact when the error actually occurs. I think here we have to thank the WHO for the good work that has been done in terms of patient safety and quality. There have been various initiatives and license forms since 2004. But what is remarkable is last year, in May 2019, there is a World Health Assembly resolution on global action on patient safety. That's the first time where it's a very comprehensive and multifaceted patient strategy is being actually achieved. And at the same time, after that, there is this global patient safety action plan for the next decade. So starting next year, we'll be looking at the action safety plans that arise from this resolution. This was actually done in consultation with many experts and stakeholders from all over the world, including those from the WHO Global Patient Safety Network. And this is thanks to the department led by Dr. Lee Lam, the Patient Safety and Quality Department in WHO in Geneva. I'd like to mention one particular important point about this global action on patient safety. That is to recognize that the most adverse incidents can potentially be avoided with effective prevention and mitigation strategies. This can include appropriate policies, improved policies, data systems. So data is very important. Redesign the processes of care, looking at environmental hygiene and infrastructure, and better still, in terms of having better organization culture to improve the practices, and also improving the systems, and also having good communication strategies. And these solutions can actually, some of them be simple and inexpensive, with the value of prevention outweighing the cost of care. For example, previously we have hand hygiene. Consistent use of hand hygiene will reduce, infection rate, and that will actually reduce harm to the patient. And the introduction of a consistent use of a surgical checklist actually prevented a lot of harm during surgical procedures, operation on the wrong side, on the wrong patients, and various aspects, looking at antibiotics use and allergies used while doing the procedures to prevent adverse incidents from occurring. So quickly, I just mentioned one of the quick actions for the UHC performance. Basically, it's important to have the mindset and the so-called rule of engagement to make zero avoidable harm, to build high reliability health system, to assure the safety of every clinical processes, be it medication, procedural, and various aspects of transition of care. And very importantly, data is important to ensure that there's a constant flow of information and knowledge to drive this mitigation of risk, to drive the reduction in the levels of avoidable harm and the improvement in the safety of care. And added upon this is that we need to be able to educate our health workers to contribute to the design of this system, as well as having partnerships with everyone that can help to improve patient safety, and of which one of the most important stakeholder partners is actually the patients themselves. So I'm very happy in this meeting that we are all looking at how we can empower our patients and families to help and support the journey towards safer healthcare. In terms of zero harm, many hospitals are looking at patient safety goals, and they look at the 6 goals, basically identify the patient correctly, improve effective communications, improve the safety of high alert medications, ensure correct site, correct procedure, correct patient surgery, reduce the risk of healthcare associated infections, and reducing the risk of fault. So these are important patient safety goals that must be achieved, that a lot of organizations will try to achieve. But what are the barriers coming here? What are the barriers to integrating this? One of the most important is actually the lack of awareness, understanding of know-how among all the stakeholders to be able to achieve that itself. Another important thing is to be able to promote political will and leadership nationally and globally itself. And finally, I come to the aspect about the stakeholder partnership, of which the patients themselves are the most important stakeholder, and that is the role of the patient's advocate. Here, if you look at it, in order to have a good patient safety and quality ecosystem, you must build up all your cultures that will support that. Speak up cultures, reporting cultures, safety cultures, learning cultures after you have done that, just cultures to be fair, support cultures, and of course we must educate patients and in terms of the awareness culture itself, and want to reduce the other counter cultures like blame culture, hierarchical culture, or paternalistic culture, or even the fear of being sued itself. So in this ecosystem, the patient also plays important role to be able to promote the cultures, the important culture, the foundation cultures of patient safety and quality ecosystem. For example, they could be, providing a lot of feedback, speaking up to ensure that data from them can be processed, and we can actually learn from the experience of the patient. They can be involved in quality improvement culture. So patients are now in quality improvement projects within the various healthcare organizations. Right, so just to summarize, patient leadership and partnership is important to strengthen our healthcare system. They need to have a broad understanding of the system and the framework for our patients. Our patients need to understand the ecosystem of patient safety to support the foundation cultures and to mitigate the counter cultures. And all in all, there's active engagement and proactive involvement of our patients and our patient advocacy group. So I'd just like to end by saying that I'm actually very happy within SingHealth that we will be able to start a patient advocacy network. And I found out that we actually unleashed the power of the patient advocate. It has done so much to improve, the experience as well as the safety of our healthcare. And it's led by Eileen and Ellie, who are actually cancer survivors. They will tell you their stories. And there's a membership group, patient experience talk work group, and plain and kind language work group. We teach doctors how to, communicate with patients effectively in a way that they can understand themselves. So I think this is the way forward, and I'm very pleased at this second Asia Pacific Congress we are able to share on this. Thank you very much.
Thank you, Professor Tan, and thank you also not only for sharing your views and your experience on how patients should get involved into the learning of the healthcare system, how to avoid harm, but also for sharing your SPAN network. And I would really encourage patients from the region and globally, of course, to join this network and to see how they can get empowered, or how can they share their experience so that other patients are empowered. We are now moving to a little bit more specific, if I can say, area, and more precise, because yes, involving the patients in the day-to-day work of the healthcare facilities is one thing, but involving them in the wider procedure of the accreditation is even more important, I would say. So I would like to invite Professor Bhupendra Rana to also share with us what are the possibilities, whether we are doing it enough, or whether we can improve the involvement of patients in the accreditation and standard procedures. The floor is yours, Dr. Bhupendra.
Thank you very much, Neda. First of all, I'm really grateful to IAPO for inviting me, Dr. Ratna, Kavaldeep, and Neda yourself. Thank you very much for giving me this great opportunity to talk to the APPC Second Asia Pacific Congress, and particularly sharing the platform with eminent experts like Professor Jha and Professor Tan. And I think after listening to both of them, my task, I feel, is very difficult, because some of the contents would be overlapping. Nonetheless, this topic is so huge that maybe a couple of people keep talking and still differentiating what they are talking about. So I'm just going to talk about specifically a role of accreditation in universal health coverage, which would encompass several other things as well. So this is the outline I'm going to take forward. Is UHC, patient safety and quality, and UHC and role of accreditation, and some concluding remarks. So as all of us most probably are aware by now, is Sustainable Development Goal Target 3.8 very clearly define achieving universal health coverage. And it's just not getting stopped at the definition, but it encompasses several other factors and parameters which are essentials to achieve universal health coverage. So I like this, this picture, which I try to draw to give a correlation on our universal health coverage. I see it as a three-legged chair or a stool, whatever you call it. It's accessibility, affordability, and quality. And I call it IQA, and keep the quality in the center. And if we know the philosophically, if any of the leg of this stool taken off, the stool will fall off. And who is sitting there is the patient, who is receiving the care in the entire healthcare ecosystem. So essentially, to keep this patient safe in terms of his sitting around, we need all these three legs: accessibility, affordability, and quality. And that's the essence of universal health coverage. So if we talk about accessibility, and I think there are a lot of work going around, what I try to capture some of the highlights that there need to be a strong public health system. Otherwise, it's very difficult to achieve. We need to support and leverage on private healthcare as well. And most importantly, uniform distribution of healthcare facilities. I see a couple of countries, including India, that some of the areas are highly clustered with healthcare facilities, and certain do not have any healthcare facilities along. So it's need to be equally distributed, and that's why we can have an accessibility. Most importantly, political commitment and will to make it happen. Without the country leadership, the governmental leadership, political commitment, it's not going to happen. And last part of the accessibility is innovative approaches. How we are moving forward, seeing into changing scenarios like we see COVID-19 now. How we change our approach to healthcare, to provide care to the patients, like healthcare, home care. These are coming up in innovative approaches. The second leg is affordability. In India, particularly, we give an example of our national health insurance scheme, which is called Pradhan Mantri Jan Arogya Yojana, most popularly known as Ayushman Bharat. There are several other countries who have adopted a public health insurance scheme to offer care to their patients. Health financing mechanism lead to look into it. The process improvement for healthcare, how we reduce stays, how we reduce the repeat procedures, and all these things somewhere revolve on quality and safety. And I will just link all these things to that. Now come to the third leg, and which in my opinion, being a quality personnel, is very, very, very important, and which actually drives all other components as well. And I'm happy to see that Professor Jay touched upon and Dr. Tan actually touched upon. I see there are 7 components of quality of care. First is safe. And we're talking about patient safety, and that's it's all about. The second is how effective it is. Just providing care is not enough, but it needs to be effective. It needs to be timely. It needs to be efficient. And sometimes when I get the discussion with my colleague, and I had discussion in last couple of months in this pandemic, that it's very difficult to follow procedures in emergency. I say, yes, I agree with you. But what about you take 100 patients, don't follow the procedures, and you only make sure that 50 patients go out right. Instead of following procedure, not take 100 patients, take 80 patients, and 50 patients go right. So percentage of the outcome which become better is more when you follow procedures. It's not just numbers. You just need not to be efficient. It need to be effective. So efficiency and effectiveness has to go hand in hand. Of course, equitable need not to be differentiated based on any background, any social economics or social status or geographical distribution. It need to be integrated. It need to be very holistic. We need to take encompassing different dimensions of healthcare. And last but not least, the patient-centered, the pupil-centered, person-centered care. We have to move away from treating a disease of an individual to treating an individual, because individual has its own individual characteristics, inherent properties. If a specific medicine may not work exactly on 2 different people, so the approach might be different. So that's why we have to move, and I'm happy to see the world is trying to move slowly toward people and person-centric care. Now look at this beautiful picture, which is quality. My only concern is how to keep this as beautiful as it is now. That's the biggest challenge in front of all of us globally, that can we make this beautiful plant as beautiful as I can see and you can see now at all the time. Quality is not about that I see today it's like this beautiful, but maybe not tomorrow. It's not my wish. It's not my thinking that I would like to see quality today and I don't want to see quality tomorrow. No, it can never be. It has to be at all times looking beautiful as it looks just now. You look at the global efforts, and all of us are, I'm sure, in this profession are aware that WHO Global Patient Safety Action Plan 2021-30, which aims towards zero patient harm in healthcare, in the released draft of August, very clearly put this specific point. Patient safety is a strategic priority for modern healthcare and is central to countries' efforts in working towards universal health coverage. So without patient safety, UHC is incomplete, and that's the global agenda of WHO at the moment. Look at the 3 reports which came out in late 2018 from 3 different very eminent group of organizations. First was Crossing the Global Quality Chains to Improving Healthcare Worldwide, came from National Academies of Science and Engineering Medicine from US. Delivering Quality Health Services, Global Imperative from WHO, World Bank, and OECD. And the third, High Quality Health System in Sustainable Development Goals era, Time for Revolution, the Lancet Global Commission. And you look at the essence of these 3 reports, somewhere or some point, somehow they touch upon quality. Somewhere they touch upon safety and how these things can make it happen. Some of the excerpts I try to pull out of these reports. I'm not building on data, but data is quite available. I'm just trying to provide a higher level of overview. So an increase in institutional deliveries from 14 to 80% in India did not reduce maternal and child mortality due to poor quality of care provided at health facilities. So it's about quality of care. It does not only that if you shift from home to institutional delivery would lead to better outcomes. A study in China, India, Kenya found that out of only 25 to 50% of the time, people received evidence-based treatment for conditions like asthma, chest pain, diarrhea, and tuberculosis. Very significant number. Poor quality health systems results in more than 8 million deaths per year in LMICs, which is a huge global burden of more than $6 trillion. So health providers, particularly in lower middle income countries, has to pay more attention because more often it is neglected. And for example, only 2 in 5 women delivered in a facility were examined after 1 hour after birth. This is very, very critical for the life and death of the mother and child. So how we are looking at? So coming to the basic of what we're talking about, the role of accreditation. It's an excellent tool. Excellent tool. It measures organizations' compliance against standards. And I'll just pitch on the standards a little later. It promotes teamwork. It increases capacity for managing quality improvement and safety. It helps in improving communication, collaboration, and team building. And as we know, the communication in healthcare is very critical and very essential to make things happen the way we want it to happen. Just miscommunication amongst care providers, between patients and providers lead to disasters. High level of integration of services. I've seen in my own personal cases as well, when I get treatment from one doctor and I have some other problem, these 2 doctors don't talk to each other. One comes, look at me, give me some medicine. Another will come in, look at me, give me another set of medicine. They don't talk to each other, and I'm get frustrated. And why you're not talking to each other? Why it is not involving the teamwork? This provides organizations with critical part to achieve improvement. So the accreditation plays a very critical and important role in quality and safety. And look around the standards framework for accreditation. It's basically talk about structures, the processes, and outcomes. And we lack globally in all these 3. Somewhere structures are not set right. If they are right, then process is not in place. And if they're on process, we are not measuring outcomes. So the accreditation really helps healthcare facilities to put them on a path of looking at their proper structures for the care they are supposed to deliver, the processes they are need to put in place, and then start measuring their outcomes to say where they are heading to. So some of the examples what my
Professor
organization already,
Bhupendra, if you can start to wrap up, my apologies.
yeah, just finish up. And it's in QI accreditation standards and linking with universal health coverage is a 3 standards for home healthcare, standards for telehealth, and for dialysis. I look at the standards for home healthcare, which actually is very linked with universal health coverage. You are able to provide access to people at home, which they are not able to go to the hospital. So accessibility, they are economical than hospital care. There is an affordability. And when these home care providers are accredited, it ensures quality. So all 3 components are taken care of. Similarly for telehealth, it's provide accessibility, affordability, but the 3rd component might be missing. And therefore, there are opportunities and there are threats. We see telehealth, talk of the town and everyone here. There are excellent modality. This is an opportunity, but there is a threat. It should not move toward a call center approach. It's different than other industry. We are talking about human being, is different than other industries. So my caution is that we should not be moving telehealth towards a call center approach. In concluding, I would say the universal health coverage needs to be a high priority for national governments. Accreditation is an excellent tool to support universal health coverage, 3rd leg, which is quality and patient safety. We need to leverage on innovation and technology. We need to implement national patient framework. Patient safety frameworks are essentials to be implemented by each country. And lastly, but not the least, strengthening public-private partnership. Without public-private partnership, it's very difficult to make a very robust and worthy healthcare system in any specific country. Thank you very much. Thank you for the opportunity. Thank you. Over to you.
Thank you, Dr. Bhupendra. And as you rightfully said, public-private partnerships is something that we will be striving more and more, because we are all now facing the challenges of the public system having to take the entire burden on itself. But going even a step beyond is that, as you mentioned, accreditation is a great tool in which patient has to play a role, so that we ensure that the quality and safety are there. Because at the end of the day, patients, all of us, we trust doctors and the systems with our lives, if nothing less. So in that sense, at least to the minimum, what we can expect from the systems is that they take our opinions or expertise or experience into account when they try to treat us or other patients. We don't have so much time for discussion, but I would like to refer to the Q&A tab. We have few reflections from the audience. Praveen Sheet is really pointing out to the importance of environmental issues by Professor Khan. Thanking on that, thanking Professor Bhupendra for really referring to the India's examples and to the India's experience. And in that sense, we have also one question from the previous session. If we can just, one of you, slightly touch upon that, maybe Professor Tan, I believe, although it refers to India, but it's more about how we can include the different health workforce or the different stages of the healthcare into the better and safer systems. This question in particular refers to the pharmacists, and I'm a pharmacist by training, so I gladly take it. So whether and how we can have the entire spectrum of the health providers and social care providers, community providers into the safety. Very briefly, less than a minute, if possible. Thank you.
Sure. So thanks. That's a very important question, in fact, and that is something which we need to do more and more. use of technology, as I said, is critical to this. So we can use technology, we can use algorithms, and we can train our non-physician healthcare colleagues, which include pharmacists, which include frontline healthcare workers, nurses, etc. In fact, we have done that, but that requires us to develop a paradigm which we test through appropriate implementation research and see that that kind of treatment approach is acceptable to the community. So that's something which we must do, but we must take a systematic scientific approach, develop evidence, present the evidence to the community that is going to be affected by that, so that they find it reassuring that they are getting not second-class care, but high-quality care still.
Thank you. Thank you. Any other reflections on this point?
Yeah, in terms of the community care, we realize with COVID, sometimes patients are fearful of coming to the hospital. So sometimes we should really set up care, project our care to the community. For example, in Singapore, we have a dormitory worker issue where there's a lot of infection there. And I know that we actually project our care to near the dormitories where the workers can seek care, as well as get them sort of confined to that particular area and not coming to the hospital where they mix with the general patient, and that will increase the risk of infection. So that there has to be an innovative way of doing that. Patient citizen must be agile, able to respond to situations, for example, in COVID, in order to be able to better serve the community.
Yes, yes. And I think this pandemic has shown us, has pointed us very much on the not only weaknesses, but also the opportunities that we have to improve the care. And as you both said, I mean, I can kind of see very much similarity with what you have shared with Professor Vivekanand on this point, is that we are not seeking to replace the health workforce. We are not seeking to replace the wisdom and the knowledge and the empathy of human to human, but technology can help in really reducing the burden of the mechanical tasks of checking and going back and forth, so that we can actually spend more time on the interface between the doctor and the patient, so that it becomes safer. Dr. Bhupendra, would you like to?
Yeah, I think it's a great discussion, and I think how to engage community. And as I mentioned, COVID-19 has taught us so many lessons, and how home healthcare has changed the whole paradigm. When patient is hesitant to go to hospital were closed as well. So home healthcare providers were able to reach out to them. So that's and now management of the COVID positive patient at homes, which are asymptomatic, but it's a great way of engaging with people, with the communities, so that they get a confidence that even the hospitals are not operating, they can get care at their own places when they need it. And I think telemedicine also helps making this more viable options for everyone around in the healthcare system. So I think use of innovative approaches and technology, but again with the caution, not moving toward just in numbers, but quality numbers is very important and essential. Thank you very much.
Yes, thank you.
Thank you, Neda. We are just at the end. Just to wrap up,
Please.
I've been given instructions from WHO to mention that the World Patient Safety Day 2021 is on 17 September. Please gear up for that. We hope we will have a physical event, and I think we hope to meet you somewhere in Geneva and elsewhere. But please wrap up and we can go on. Thank you.
Thank you, Kavaldeep. It was really a pleasure to be moderating this session. We certainly look forward to continuing to interact with you, especially with the latest initiative of IAPO to have its own expertise resource center that will be called IAPO Patient for Patient Safety Observatory. And this is an initiative that we are launching together with the WHO, more so to find a good space or a medium where patients can, first of all, share their experiences, but also get empowered as to how they can try to really make the difference, and not only be the users of the system, but rather be their co-creators and co-designers, so that we can all really see zero harm very, very soon, and take the patient harm in the history of medicine, hopefully. Thank you all very much. Kavaldeep?
Yeah, thank you very much. I think I would ask the audience to join us after the break, after the mobility break. And once again, please do tweet and please do share this. It's a very important session. Thank you. Bye.
Thank you.
Thank you.